so much for joining us for part 2 of the Surgery Department Survive and Thrive webinar series. Today we're going to focus on using data to improve safety, quality, efficacy, and utilization. We'll show how an analysis across the continuum of care provides a big picture into the realities of healthcare. We will outline how hospitals justify investments in analytical technologies to create real-time event-driven analysis. We'll explore methodologies to build a case to become a player in the data game. And in order to keep background noise to a minimum, everyone will be muted. We encourage your questions at any time throughout the demo. Just type your question into the chat box and we'll address them at the end of the session. Our presenter today will be Stephanie Randa. Stephanie is the Vice President of Analytical Solutions at YourCareUniverse. She received both her MBA and her MHA from the University of St. Francis. She's also certified as a Lean Six Sigma Black Belt, a registered nurse. She has a membership in AORN, ANA, and TNA, and is also certified by the nursing, also holds a certification from the Nursing Operation Room program. So thank you so much for being here today, Stephanie. We look forward to the presentation.
Thank you, Lauren. This presentation I am also presenting at the Association of Operating Room Nurses next month. So you are getting a preview for before everybody else. So hopefully if any of you are attending, I'd love to see and hear from you. And hopefully you will enjoy this as well. We've already gone over the objectives as far as what we're going to be covering today. Lauren has reviewed that with you all. And we'll go ahead and start with our first polling question. So who is in our audience today? What we're just kind of interested as far as who is participating. A is staff nurse or clinical leader. B is director. C is business manager. And D is decision maker for the OR or the organization. So the poll is open, and we'll just give it a second here. Things that I wanted to be talking about is really about a movie that was actually a film in 2011 called Moneyball. And this really resonated with me because it really to look at how some of the Oakland Athletics baseball team actually moved from the bottom of the bottom of the game to really the top of the game, with really only a quarter of the payroll dollars of the New York Yankees. And so the reason that they did that, and they were actually able to get into the playoffs, is that they really started looking at the data analytics versus the typical ways of decision making in baseball, as far as team building, building your team based on batting averages or runs batted in and stolen bases. And so the reason that this kind of resonated with me is that typically in operating rooms, as directors or managers, we're trying to really attract the best. Of course, we want the best type of employees, but many times what we have to do is we have to grow our own, because there's the aging workforce and there's not a lot of folks that are trained as far as operating room nurses. So this is kind of one of those things where you have to really be smart about what you're doing and really look at what really matters and what are the data and some of the analytical information that you could really use to drive the strategy just on some day-to-day decisions and really move your department to be the most cost-effective and have that competitive edge, as well as quality and safety issues. So what do we mean by big data? I think that's always been kind of a question for me. And really there's really a big difference between big data and business intelligence. Business intelligence is really around something that's very stagnant. It's a quantified amount of information. But really, when you're thinking about big data, there's large volumes of that. It is really new information is coming in all the time, so it's not necessarily a year old, and sometimes we see that with analytics. Some of the information is old, so it's hard to be making quick decisions if you're looking at old data. And then there's a variety of it. There's a lot of information that is coming from different places, and so and it's very complex. In the electronic healthcare record, not only are you getting information that is in certain fields that you're filling out, male, female, left, right, those kind of things, but you also have information that might be in notes, and so that a lot of that information has to be pulled and sorted through. And again, with the large amount of information that we get from the internet and any digitization of publicly reported data in health records, that's also a large amount of information. So what do we do with that data? Well, a lot of times we're looking at costs and outcomes. I know I spent a lot of my career looking at how we can reduce costs but still improve outcomes. And you want to be able to also look at some of the clinical information around the social and demographics as far as risk factors. So a lot of that is very important because you want to do some predictive analytics as well. You want to identify who's your sickest patients and where are those patients in your vicinity, in your community, or in your region. And you also want to look at those physician outliers. And we'll talk about that, and I'll show you what I've seen. Sometimes those physician outliers or your highest volume physicians aren't necessarily your best performing physicians. And so you also want to be able to look at those costs and then determine what is really driving some of those costs. I think the hardest thing when you're talking about data is that you really have to do some cleaning and you have to validate that information because, again, just because information is put in, it doesn't mean that it's necessarily good information. Garbage in, garbage out, so as we say. So you want to really be careful. You want to be able to validate that information and making sure that where the information is coming from, you want to make sure that it's clean information. Sometimes people put in numbers where it really should be a letter. And so if you don't have a force field to do that, I know I'm looking at some information right now, and you might have male and female, and that seems very clear, but if you could put an M or if you could put a 1, that information isn't necessarily clean. So you also need to be able to extract it and be able to make sure that that information is again, valid for you. Where does the information come from? Well, the information from our electronic health records can come from a lot of comprehensive sources. It could come from financial information. It could come from your clinical information. You have various encounter records, so a lot of times one patient may come in multiple times. So how does all that information kind of get brought together into one record? So you want to make sure that it's really, you're knowing where that information comes from. Sometimes we get payer information from CMS or claims data or clinical information as well. Sometimes we are providing information to CMS, Medicare, on our clinical outcomes. So again, we want to make sure that that information is very clean and accurate. And then there's the community information. And again, we'll talk about a lot of the demographics and psychographic information that we could get that really helps us pinpoint more accurate data. So let's go to our second polling question. How is your organization using data? Are you using it for cost containment? Are you using it for data retention and compliance? Basically, is it just because of the Affordable Care Act we have to do it, so therefore we are? Or are you doing some research with it? Are there some clinical trials that your hospital might be participating in? So the poll is open, and we'll give you all just a few minutes to look at that. All right, and the polling's closed for the second question. So with HIMSS, according to HIMSS, what CEOs are seeing is that they say that they are using 35% are using data to improve patient care. 31% are reducing costs, and 28% improving the health outcomes. And then we have increasing early detection is at 22%. So I think that's probably pretty close to what you all are doing as well. So this probably is a slide that you all have seen. I know it's I've used it quite a bit, but it's really about identifying what's the problem. Why is it that we're so interested in the healthcare and data analytics around healthcare? This is really a cross-national comparison that's tracking the performance of U.S. healthcare system and the United States, and then several other countries. And this spending includes the supplies, utilization, prices, and health outcomes across 13 high-income countries. And so the healthcare spending in the U.S. really exceeds any other country. And the interesting piece is that the U.S. in this information here is is really only the country that is without a publicly financed universal health system. So, but we still are spending a lot of dollars that either the government is paying for or we're paying out of pocket. So this again is some information that's that's nationally known, but prices for hospital and physician services for a surgical procedure. So if you just look at the bypass surgery at $42,000 in Australia, and then you drop down to the bottom of the second column, and the United States is at $75,000. So that's more than $30,000 higher than the second highest country, which is Australia. And when you look across the board, again, our spending is much higher, and we really have to start identifying that and looking at how we could work to fix that. So the one area that I always like to look at, I know in my career as an OR director, is really around your total joints, and that really kind of makes and breaks your surgery department, how well you're doing in orthopedics. But approximately there's 700,000 knee replacements that are being performed annually in the United States, and this number is really projected to grow by year 2030. So, and again, a lot of this is because of our aging population, but again, we have to know that the orthopedic business is a thriving business right now in the United States. If you look at total hip arthroplasties, that growth, we're going to be up to 572,000 annually. And then the revisions, of course, and that really makes sense, is around those revisions of hips and knees, because again, if we're getting them put in, we're going to have to get them replaced as well. So, and that growth is up there. So there's some variability in the costs with those joints, and I think that's the piece that we really want to address. There was a study done with the total knee arthroplasties and the total hips in 2014, and it really found that a lot of patient characteristics of anatomy drives a patient's decision for the implants. There's also some cost characteristics, and then there's a field that's within the hospital, and that's really which means the surgeon preference. So if you look at the first graph, the average total knee implant, the reason for those variation is really only 2% was because of the patient had a particular type of abnormality that needed addressing, and that's what drove the cost of that implant decision. And then if it was really the hospital, that's really around the surgeon's decision, and then the other was due to 37% is really due to contracting. So that is quite a difference as far as making a big impression as far as the overall cost. So I think we have to acknowledge that. Some analysis of total knee costs. Again, the average selling price of the total knees is really about $5,400. The Medicare spend is $1.7 billion a year, and there's really not a lot of evidence around the utilization of some of these higher, more expensive implants. So we really have to identify that, and I think a lot of times, I think Medicare is really unable to make a decision based on the need. So I think that's why we're seeing some of these costs right now. I think a lot of times our sales reps are also someone that could help influence and make decisions. I know many times we would be very excited to have a contract finally get negotiated and the physicians agree to that, to using those type of implants, only to find out that just a few months later there was a new improved type of implant that the same vendors were also then selling and letting the physicians know. So those costs have to be taken into account, and it's really hard to address those. I think the other thing that's out there now is your robotic total knee arthroplasty. This, as far as the analysis, the accuracy is very improved. That's great. It does take longer as far as the operating time. There's about a $1,500 increase in cost, but there's really any data that supports the outcomes. So you really have to, kind of still look to be able to compare that. Is this more effective, and are you going to get longer-term outcomes? Because that's really what we're looking for. Big data is really used by other industries as well. I think, as you see on the slide, there's petabytes. I've never heard of the amount of petabytes of data that's used every hour from consumers. 10,000 credit card transactions are made every second, and that information then is going towards making other decisions that are affected by, as far as retail and what you're buying. So where does it all go? There might be some technology. In June 2013, it was reported that the government is using big data technology to spy on Americans as far as looking at what type of companies that they are using. In the future, I think there's going to be still large amounts available to businesses. Macy's uses a lot of information just on as far as their mobile. They looked at the data from the mobile phone used to find out how many people were in their parking lots on Black Friday as far as the shopping seasons go. I think banks are using information more and trying to be more predictive about the type of clients that they lend money to. Churches are also using that information as far as analyzing the websites. They're very specific as far as looking at the type of events that are attended, and then the financial and the cost that they're getting. Some of the other industries that are using big data is, of course, sports. We already talked about baseball, but many basketball teams are collecting up to 1 million data records per game. They have tiny cameras throughout the basketball courts, and so they're analyzing their team's plays and the players, and if they're then making any adjustments according to the data that's coming in. Of course, being in the political season this year, a lot of information as far as the polls that are coming in and the predictions, that information is out there as well. Again, the banking industry, since the mortgage crisis, they've been very careful about who they lend money to. I think the exciting areas is really around science and healthcare. I think as far as we're going to need more data scientists and more need to have more business intelligence there was an article in last week's Wall Street Journal that was identifying this as well. So there's going to continue to be a large need for those people in the data analytics world. I think in healthcare, I think what we're probably going to start seeing is that science and healthcare will come together. So so that we would be able to use data scientists in these that's doing research and maybe share information. So again, things will be turned out and information will be shared more easily as far as pharmaceuticals and medical devices. I think there's the number of areas that we look at as far as analytics, and if you could, really think of it as there's the global view. There's really a large amount of information across the country. You then could look at it at your perhaps your corporate level or your hospital level, your market level, and you could continue to drive down a little further as far as your community level. What does it look like to your facility? What is it that the households are doing? What are they buying? And what are your patients and consumers really doing and looking at? If you look at this is just a slide that I pulled from, it's from Nashville, Tennessee, Davidson County, and this is the area that we're in, as far as the overall household income. And as you see, it makes a big difference as far as you look across the spectrum. And so what we want to be able to do is also look at our population by age within this same household and their income, and look at their race. And so when you start then looking at it at all these different factors, you're able then to put a picture together as far as what type of patients that we may potentially have. As you see, we are projected to have our aging population, 55 to 64-year-olds, is really exceeding our 2015 levels by, and so we are going to be having a population that's going to be growing older. It's not only are we going to be looking to market to these type of individuals, but you really then want to slide back over at the 20 to 24-year-olds, and by 2020, that isn't growing as fast as we would like it. So these are the people that maybe be taking care of us as we're growing older. So I think you have to look at that. So if you're a hospital, you want to start recruiting and trying to make sure that you have nurses and physicians to take care of the aging population. So this is how you could use information from as far as your overall community. This is around cancer mortality, and again, this is the county that's our metro county that we're in, and then it's looking at it as far as our Davidson County. It's looking at Tennessee, and then it looks at cancer mortality across the United States. So as far as our population, our non-Hispanic whites and our non-Hispanic blacks, those numbers are growing. They're larger than the non-Hispanic blacks then are larger than in our Tennessee area, and then also in the United States. So now we want to slice it just a little bit further and really to look at how that thing starts to compare, just looking at breast cancer incident rates within our community. And so again, the Davidson County area is definitely growing as compared to Tennessee and the United States. So what that means is as we start looking at how hospitals are marketing to us, I've noticed that there's a lot more commercials on TV as far as cancer centers, how we're using gene therapy to battle cancer. So I think that is something that hospitals as a whole are starting to get a little more into the marketing focus, because you're able to look at these kind of incident rates and the trends that we're going to be seeing. This is just an example of information that we would be able to see from our particular primary care physicians, and how then they are able to influence some of our specialists. So many times we think it's really our specialists that are really driving or attracting patients. And we talked about orthopedics. Orthopedics is in the green there, and that may not necessarily be the case. It's really your primary care physicians that can be growing your business or influencing it. So you want to make sure that those physicians, those primary care physicians, are knowing, are they referring to enough of your physicians to these orthopods that could make a difference to your volumes, your surgical volumes. I think one of the driving factors around a lot of our costs and kind of the Affordable Care Act is really around the triple aim, and that's where Don Burweiss and his team from the IHI really identified that there's really healthcare improvements that really need to be had, and that is really needs to be done at the federal and the national levels, but to really reform our healthcare system. And that is really focusing on 3 dimensions of optimizing the healthcare system. And that's really improving the patient experience. Do patients have to wait a long time before they're able to see a physician? Do they have to wait a long time for care, whether they're waiting for getting the lab, getting the x-rays, getting on the surgery schedule? We want to improve the overall health of the population. So again, if we have a population that we know has particular issues or disease states, then we want to make sure that we're able to address those as a whole. And then reduce the cost of healthcare. Again, looking at the cost across that continuum and see what we could do to reduce it. And we identified our joint costs are one of those areas that really needs to be looked at. So we have a polling. Let's look at our third polling question. And this is kind of, again, what can you do with data? So what are you doing to really combat surgical site infections? And how are you using maybe some evidence-based information to help you with that? MRSA, indeed the decolonization protocols, is those being used? Are you using antimicrobial impregnated wound closures and post-op dressings? Are you adhering to temperature and humidity guidelines, or A and C? Okay. Well, again, if we look at the data and some of the evidence-based outcomes, we want to really make those decisions based on that. We want to use the data to support our clinical decisions. We want to increase the quality of care, reduce errors, improve efficiency, and really reduce costs overall. We want to increase that provider and patient satisfaction. And so as far as for the infection prevention for 2016, some of the evidence is really pointing to patients really need to have that preoperative assessment to really identify any type of issues or high risk that patients may have. Using the MRSA decolonization protocols is one of those ways of doing that. And so you want to identify patients that have that risk for surgical site infection, and if they have, only if they have positive results, do you want to then prescribe the nasal Pyrosin, or you want to use the CHD-based antiseptic cleanser for home use. So those are some of the things, again, that evidence supports. You don't want to just do all kinds of things, multiple things, and hoping that something is going to make a difference. Some places where you could find some of those evidence-based protocols, the AORN standards, the Centers for Medicare and Medicaid Services, Center for Disease Control and Prevention, American Society for the Heating, Refrigerating, and Air Conditioning Engineers, and then the Medical Advancement of the Medical Instrumentation, AMI. So those are all the areas that you could really look to help support you in what you're doing as far as protocols. Here is, if you're using perioperative data, here's just an example of how you could use it in the preoperative area. If you're looking at the adult diabetics, what you're looking at is it's more than likely to happen to Americans age 65 and older. 25% of the seniors are diagnosed or undiagnosed. And so we know that diabetic patients have a higher risk of infections. And again, we don't want to do throw the kitchen sink at whatever evidence we know that could work, but we really want to be able to make sure that we are identifying our high-risk patients and focusing on those. As we said, 25% of those patients have that, are diabetic or undiagnosed. So your 20% of those patients can affect 80% of your spend as far as your surgical site infections. So again, you want to be able to spend some time on those. In the intraoperative data, some metrics that you want to use, you want to be able to use metrics to really improve your overall performance. You want to look at your cost per case, and you want to look at labor costs. Some of the, if you want to dive a little bit deeper, here are 7 most important metrics to really measure efficiencies in the operating room. Your first case on time starts, your turnover times, your percentage of locations as far as what time they're used. If you have several locations, I always like to look at the concurrent rooms. Are there any complications? We're going to look at value-based purchasing as far as the overall cost, consistency of service, and then the overall outcomes. This is an analysis for, back to our total joint physicians, but we did an analysis on 2 physicians that for their supplies. And we looked at as far as what their overall supply comparison was. And again, a lot of times your administration may really push you as far as you may have a physician that has your highest volume, and so they don't want to do anything to maybe upset that particular physician. And so what we did was look at Dr. B, or let's call him Dr. Bill, and Dr. P, Dr. Paul, and Dr. B, his overall cost, or his overall number of supplies, was really lower than our Dr. Paul as far as that goes. But when it came to the overall costs, although Dr. P or Dr. Paul was a high volume physician, he also had the highest cost, higher than Dr. B. So again, I think as we were talking about the money ball, always trying to have your high volume physician, it may not be necessarily the right thing to do. You want to try to also bring down some of those costs. We were able to show him the detail of some of his costs, and he was able to bring that down. And again, I think a lot of it is awareness as far as what the overall costs would be, and that usually has been successful in my experience. So many times we don't necessarily look at what happens post-operatively to some of our patients, but I think this is just an example of a tool that we have here at MedHost. It's our throughput tool, and it's similar to a bed board, but what it does is really kind of quantifies patients that maybe are actually maybe have been staying longer than what is expected, and so those are identified, and those costs are really identified. And you want to give reasons as far as the length of stay. So here's just an example of, here's the number of patients that maybe exceeded what the DRG was for a particular patient, and as far as so you can know what and the reason for that. This also then lets you know as far as what kind of potential problems you may have as far as beds and the overall cost that is associated with that. Because if you aren't able to get your patients out of your PACU, that just adds to additional cost, patient dissatisfaction. It's also becomes very apparent that patients' length of stay increases about 20% if they're not necessarily on a specialty bed. So if you put an orthopedic patient on a med-surg floor, the length of stay could go up about 20%. And again, just looking at what those discharges are and how those can be maybe prevented with using data to help drive some of that. And again, I know a lot of times as operating room leaders, you're looking at a lot of data and you're trying to determine what is it that you really need to be focusing on. I think there's a lot of reasons that data is difficult to capture. It's in multiple places. It's really the electronic medical record provides a platform, but it really isn't easy to make sure that the data fields are completed or enforced unless you have some forced entries. There's a lot of requirements that are needed, and the data is really in multiple systems. This is just a quick visual as far as the information that comes in. If you're pulling information from, and you have data from a lot of different types from your electronic healthcare record, you could look at patient patterns and trends, but you really have to develop some insights and use some evidence-based rules to create new insights as far as what you should be doing and creating an action plan. And that's really what changes the process and facilitates change and changing what you want to do for that. Some things that as far as some trends that we're seeing as far as what's influencing healthcare, many times we're using our different devices as far as requesting medications from a smartwatch. We're receiving maybe our bills electronically. We want to get some input as far as some of our, maybe if our blood pressure is too high, we're getting that information from external sources, and we want to access personalized plans from our insurance. I know Cigna has kind of a help section on their website as well for different things if you want to reduce weight or those kind of things. There's really some of the technology out there that's going to be new for healthcare is really, really not the necessary check-in process. You might be able to receive an alert by as far as when that check-in time is, use an app for directions through a hospital, or receive notifications of wait times as far as, when your physician will see you. Some of the health IT platforms that capture data are those wearables, your phone, glucometers, and that really is the ability to connect the patient and the caregiver. We take pictures of a lot of our issues that we may be having, such as rashes, and we will be able to help triage some of those. More information as far as getting diagnosed by machines. Watson, IBM has the Watson out there, and it's really looking at information and pulling out some of the risks and predicting some of your health associated with that. Information is really not knowledge. It's one of those things that you have to not only look at numbers, but you also have to assimilate them and put them into actionable format. The key is knowing which information is really important. Hopefully this will help you as far as knowing that It's really very complex right now in healthcare as far as data, and hopefully we'll be able to help you with that going forward.
Stephanie, thank you so much for your time today, and to our audience, thank you. Just as a reminder, if you have a question, please type it in the chat box, and we'll answer them right now. We did have one question come in already. So it looks like the variability of cost has a tremendous impact on joint replacement and the variation there. Do you have any thoughts on how to make the procedures more consistent?
Well, I think as far as looking at the overall outcomes, I know that's difficult to do. A lot of it is influenced as far as the patient and their rehab, but I think the key is going to be more transparency, and so patients know what it's going to cost them. I think is really important. A lot of times patients are not necessarily interested in, as far as the U.S., having their provider make a decision as far as, I only want the best for the patient, but I think it's really going to be about knowing what things cost before we could really make an impact on total joints.
And when we were going through the exercise of Dr. B and Dr. P, is that what made the difference? Just really understanding the decisions that were being made and what they cost?
Yes, absolutely. I think from the physician standpoint, I think they were very surprised as far as what items cost. In some cases, they didn't necessarily know that. And same with the staff, they didn't know as well. So by making it really apparent, it made a big difference.
Great. So another question's come through. On a practical level, how do you gather accurate information on what is open versus pulled for cases? Do you create tools for staff to use or assign someone to collect data?
I've the one thing that I've seen that's been really helpful is to assign someone to collect the data. I know it's a bit of a tedious process, but if you can get someone to do that at the end of the case, it's a huge benefit. I've seen that particularly work on instrumentation as well. I know we always look at supplies, but instrumentation is costly to process as well.
Thank you. Well, that appears to be the last question, concluding our presentation. So thank you again for your time. We will send out the link to the recording as well as the link to the PDF of the slides by the end of the week. Thanks again. Have a wonderful afternoon.